40. From the time we knew for sure scientifically that tobacco caused lung cancer. Okay? Now things move quicker today because of internet and conversation, so maybe it wouldn't have taken so long, I don't know. But the issue is tobacco had become such a huge part of people's lives that nobody wanted to give it up. And so nobody wanted to believe that it was really a problem. And then what's the other problem you have with trying to get rid of tobacco? Tobacco farmers, right? And tobacco companies, and all of the issues, these are big issues. This is not an easy, simple thing. But again, from a public health standpoint, recognizing tobacco is a health problem and a leading cause of cancer. Now, if you were going to develop a campaign or a strategy around this, we're looking at primary prevention, you would first talk about what? Don't start smoking, right? That's primary prevention. Don't even start. Anybody who's been addicted to anything or tobacco recognizes how much harder it is to stop once you started it, right? So that's a part of the campaign. Don't smoke at all. Another part is if you're already smoking, how can you decrease that risk? Well, you can use filters. You can decrease gradually the number of cigarettes you use, right? That decreases the risk. If you're already addicted, then really the only thing to do is treatment for that. So do you see the public health process? So now that we know, and it's been, what, 50, 60 years later, we know that tobacco causes cancer. What's the messaging that we see today? What do the advertisements say? Yeah. I mean, you have all of your advertisements are very much associated around don't smoke, don't start. Right? If you are smoking and you go in to see your physician, they are always going to say to you, you need to stop smoking. Even if they know you've been smoking for however many years and they know you're not going to, do they still say it to you? Yes. That's how we're trained, just so you know. We still have that message, right? And we work with you to try to decrease that issue. But that is the message around smoking. Okay? When we think about other risk behaviors, what about, and I don't know what types of campaigns you have here in Kenya, but when it comes to, somebody was talking about addiction this morning, when it comes to illegal drugs, what is the messaging that is given to your adolescents and the people in your community? Okay, don't use drugs, right? I mean, isn't that the campaign, say no to drugs, don't use drugs? Any of you remember that campaign where there was like a frying pan, I don't know if you even got it over here, with eggs, and it says, this is your brain, a picture of a brain, and then fried eggs, this is your brain on drugs. It was a terrible commercial, but that was something they tried to kind of scare people into like not using drugs. But again, that's the message. The public health message is don't use it, right? Again, there's funding around helping to decrease it, helping to decrease the number of substances that you're addicted to, and then all kinds of treatment. In our country right now, we're dealing with an opioid crisis, significant crisis, and much money and effort is being put around trying to stop that. Training of all levels about how to help to prevent that. But the primary message is don't start. And if you are addicted, here's how we can help you. Again, you don't leave out the other messages. But that's the public health message that comes in. So in the context of optimal health and talking about sexual behavior, what are the messages that we hear about sexual behavior? Our smoking message, our drugs message is to avoid that risk. That's the primary public health message, right? What is the messaging around sexual behavior? Use condoms, okay? Use protection, right? What else? The morning after, okay? Okay. Is that a very loud message? Not so loud, but it's getting louder, right? So let's work through that a minute. Let's use the same model we used for smoking. Okay? Health problem, barrier to educational achievement, all of those things we know. Because we're trying to primarily prevent what? Unintended pregnancy, right? And so that's the problem. And when you look at the risk factor, it's unprotected sex. Right? Okay. But does preventing unprotected sex, does that really count as primary prevention? Okay. Why not? I agree with you. Because you have to go back to the beginning and decide what is the risk factor, right? So from true primary prevention, when we're talking about this, the risk factor, if you want to prevent exposure to disease or the onset of a high-risk behavior, primary prevention is sexual activity. In particular, when we're talking about adolescence, it's early onset of sexual activity, but it's also something that sometimes we forget, and that's the number of sexual partners that you have, right? When we're talking about this. So if we're really looking at a primary prevention public health message, here's what the CDC says. Another part of Health and Human Services where I work is the Center for Disease Control. And my colleagues there on their website where they talk about primary prevention, here's their statement. They say the most reliable way to avoid sexual risk is to abstain from having sex or to be in a long-term mutually monogamous relationship with an uninfected partner. Now that phrase, what does that mean in most cultures? Marriage in most cultures, right? Okay, so again, that is risk avoidance. That is the healthiest approach to avoid sexual risk. Here's my other concern, and I think this is critically important, and I will take responsibility for this as a member of a larger group of people. But back in the 90s, 1990, I was early on in my practice as a pediatrician, and we were recognizing and seeing, again, the problem of teen pregnancy and unintended pregnancy, and it was skyrocketing, and it was out of control. And as public health people came together and pediatricians came together and CDC and all these people, we decided we really need to do some kind of a campaign to really help to prevent teen pregnancy. And that was the approach we took at that time. And when you prevent teen pregnancy, primarily, the approach that was taken was to use contraception. Now that works pretty well to prevent teen pregnancy. What happened, you may not know this, but to the numbers of teen pregnancies with the onset of the use of contraception? They decreased dramatically, okay? Contraception use went up, pregnancy rates decreased. They're still not as low as they should be, but they decreased. But here's the problem. An unintended consequence of maybe what might have been a good idea is the astronomical rise of sexually transmitted infections. Absolutely skyrocketed. And if you look at the data in the United States, and it is mirrored around the world, it is at the time when we instituted teen pregnancy prevention funding that the rate of sexually transmitted infections started going up. Because the most effective ways to prevent pregnancy have absolutely no effect on preventing a sexually transmitted infection. Now, medically we knew that, intuitively we knew that, but in looking at a big problem, we skipped the primary prevention step and stepped right over into the risk reduction step, which again does reduce your risk, there's no question. And I want to be very clear here for public health people and medical people, and regardless of where you fit on your ideology around contraception, what you need to understand from a public health standpoint is that yes, you can still give somebody the primary healthiest message that will help them be the healthiest that they can be, and they still have a choice whether or not they're going to listen to you or not. Right? At that point, it is very important that they understand how to reduce their risk, both for themselves as well as the population and community they live in. So it is incredibly important that conversations are had if young adults, adolescents, adults, whoever you're talking to, make the decision that they are going to be sexually active, but not within a long-term mutually monogamous relationship with an unaffected partner. It's really hard to say. Then risk reduction is a critical public health message that we have to give. And it's very important. And then again, there is treatment that comes as a result of sexually transmitted diseases or other things. Very important that we recognize the messaging and how we want to give that and what we do. Again, not just the age of onset of sex, but does it make sense to you that the younger you are when you start having sex, the more partners you're likely to have in your lifetime? Okay? Absolutely. And do you understand that sexual activity and the spread of sexually transmitted infections, it's not just who you're having sex with. It's who they've had sex with, and all the people they've had sex with, and all the people they've had sex with, because that's how these infections are spread from person to person. So the number of sexual partners is a huge risk factor when it comes to talking about sexually transmitted infections. And you all, maybe your continent more than many others, have seen what the results of HIV have been. Where there are countries that maybe 25 to 30 to 40% of their adults are no longer there as a result of HIV. I love science, I love technology, I love the fact that we are learning things every day, but one of the problems with what is our success rates on HIV, one of the unintended consequences of that is people are forgetting and thinking it's no big deal, there's a pill to take. Right? So again, this public health message of recognizing that is something that's really important and not to be forgotten in our conversation. And that is part of the reason why the USA policy right now when it comes to our own national look at HIV is that we start with talking first and talking about this primary prevention. And then we talk about testing. And then we talk about treatment. Because you have to have the whole the whole approach, but you cannot forget the first step. And we have been very guilty of doing that over the years. Again, I want to be very sensitive here because when I talk about this optimal health model, and we talk about successes by getting to the level of better health, lower risk, ultimately hoping to go back to no risk, I recognize that there are some people that will never be no risk. That doesn't mean that there's something wrong or there's a problem. We have to be sure. When you have a public health message that says no risk is the healthiest thing for you, you cannot forget the individual people that are there that can never get to no risk for whatever reason. They were born into HIV. They have it. Not from any choice of their own, right? They are never going to be no risk. you have to be so sensitive to the message that is given around this. And you can be such a crusader for primary prevention that in a public health setting, and you forget individuals. And we must never do that. We can never lose the humanity of the individual person that we're talking to. And we can also never lose the fact that we have to meet everybody where they are in their risk area and help them get a little bit healthier, whatever that step is. Here's the thing that I think is so excited about this, because, and again, I'm a pediatrician and adolescent specialist, and so this group of people I love. It's also great because they haven't made a lot of mistakes yet that they have to fix, right? And they have a lifetime ahead of them to make good choices. But if we target adolescents and young adults, that target population, we are actually going to affect 3 generations. You talk about bang for your buck, right? Or good return on whatever you're investing. Because when we look at this, not only do we have the patient themselves, but we also have their parents and family that are going to benefit from this. And then we have the children and family that they will have someday. So you have 3 generations that you're able to impact. And when we do that, the impact of our policies and our program multiplies. And so remember that as you're looking at projects to invest in. I will be the first to admit that working with youth can be messy. It can be discouraging, but it can also be incredibly rewarding. What does optimal health for youth look like? When we're looking about this in the big setting picture, and I'm painting a picture of optimal health, what does that look like? Well, first of all, it looks like helping to make sure that as adolescents enter puberty that they're healthy and that there's positive mentoring by trusted adults or parents. There is so much social science research now that proves that some person, and it only has to be one person in that child's life that has a positive influence on them or that encourages them, makes all the difference in the world in how they turn out. This morning, our friend was talking about the adverse childhood events, the resiliency factor that goes along with that. Trusted adult or parent in their life, incredibly important. There's resources that are available to them, education, health resources to support their decision making and to support their health care. One of the things I like to say when adolescents come into my office, and most of the time they're with their parents or another adult, but I will say to them, well, here you are. When you were a child, your parents were responsible for your health. When you're an adult, guess what? You get to do it yourself, and it is not as much fun as you think it's going to be. But now that you're in adolescence, we get to share this. And so this is your chance to start to learn and take responsibility for your health and make some of those decisions with your parents' input, because they are still incredibly important in your life. Healthy social relationships. The goal would be that you want to develop healthy, safe, strong families, friendships, and communities. When we talk about adverse childhood events, what's primary prevention for that? Healthy families, right? Exactly. Helping to build healthy families will help to prevent adverse childhood events. No question. Is that easy to do? Absolutely not. But it's critical. And it's the only thing that really will make a difference. Self-efficacy and risk avoidance. And really what this means is it has to involve the adolescent learning how to make decisions themselves, learn how to respond to the coercion or pressures, peer pressure that they're going to feel from other people, but still within the safe confines of a healthy family or a healthy community. Because not all our families are healthy, let's be honest. But if you have a community, if you have a school situation, if you have a church community that can surround your child, if you have extended family, that will be critical when we're talking about this. Preparation for marriage. Again, helping them to learn about healthy relationships. What does a healthy relationship look like? What does coercion look like? How do you resist that kind of pressure? Helping them creatively think through advertising. I mean, I don't know how bombarded you feel with advertising about everything that you have to be happy, but that's what it seems like, right? And children are particularly bombarded, and if you have looked at any kind of marketing research for companies, they target ages 4 to 8. Because if they can grab a kid between the ages of 4 and 8 and get them hooked to their brand, they're hooked for life. And that's the age that they target. It's a little scary to think about. But that's a piece of what happens. And so learning how to be critical thinkers. My kids hate to watch television with me when they were growing up because I would always stop it and go, there's a teaching moment. What did you learn there? What did they say? What are they doing? They're like, Mom, you are ruining this for us. You know, well, what did you see there? What did you think about that? Again, opportunities there for teaching moments in the middle of life to help critically think through something. So, sex education, which again I know is a big topic of controversy for many countries in Africa. How does this fit into the optimal health model when we're talking about this? And again, I think we would all agree that education in itself is empowering. Ignorance can lead to bad decisions. Ignorance can lead to harm, right? So education is empowering. We all, our countries, all of us invest in education. We think that's important. The questions come up, who should be doing the educating, right? And what is the content or the source of the education? But I don't think that we disagree about the fact that education is important. What I find sometimes, and this was said actually at the conference yesterday in a session I was in, many times as I'm talking with parents, they feel ill-equipped to give that education. And so they rely on maybe the school or other people to do it. So maybe we need to have parent education, right? That wouldn't be a bad idea. But again, the idea that a healthy, stable family is the bedrock of society. And so that needs to come there. And if we need to help equip parents or partner with parents to be able to give that message to their kids, then we need to do that. And we need to look at programming that does that makes parents an important part of the program. There was a trend, for lack of a better word, in the United States of thinking that parents really weren't important and maybe we should try to pull parents out of some of our educational things. And then as most of the time we did studies and looked to see if that was working, and we found out it was a colossal failure because as adolescents would tell us, the most important person to them to give them information about sex was their parents, overwhelmingly. Parents answered that question, their peers. So the parents were completely unaware of the importance that they had. But multiple times repeated in studies in the United States show that parents are still the most important person when it comes to making that decision. And so again, we need to value that. Our policy does support an optimal health model when we're talking about sex education. And the content needs to promote optimal personal and family health, and the family as an integral part or bedrock of the society. We believe that decisions about sex education need to be made at the community level and not by the federal government in our case or international organizations, because each community needs to decide how they want to educate their kids. And in the United States, education is a community-based thing. There are guidelines and there are things set up, but each school board and community gets to decide how they educate their kids about a number of different things, and says that sex education is a part of that. It needs to be obviously culturally sensitive, but it needs to be medically accurate. And it needs to be focused on promoting optimal health. I'm very disturbed when I have conversations with people who say Well, we know that condoms don't work for all of the sexually transmitted infections, but we really probably shouldn't teach that, because then maybe they won't use them. Okay? Not appropriate, not medically accurate. Yes, there are some infections that they work better for, and there are others that they don't work as well for, and we need to be honest about that, because the worst thing that can happen is to have an adolescent in my office come in and say to me, "You said to me the condom would work, and now I have this infection." And I look them in the eye and I say, "I did not say that to you, because I know what I say. And I said that, yes, this will reduce your risk, but there are a number of infections that I can't help you with." And so again, those are important conversations that we have when we're talking about this. Again, encouraging parent-child communication and community mentoring. This is a part of the regulations that are a part of our family planning program, that parental involvement cannot be required, but it needs to be encouraged in decisions about family planning for adolescents. There are state laws that talk about confidentiality, and even in those state laws, in those states where those laws are in effect, we still require that our care providers ask the adolescents, if there is an adult, that they would like to be a part of this conversation. It doesn't have to be their parents, it can be some other adult, but this is a big decision to make. And here's the thing. When we were going through our phase of saying kids should be able to make their own decision, we didn't have the brain research that we now have. And this is a point where we have policy in place and we have new research, and we have to look at that research and then relook at our policy and decide if we need to change things based on that. But we know now that the developing adolescent brain is not fully developed until mid-20s, and we know that the part that develops last is the prefrontal cortex, which is the part that helps you make decisions based on reason and not emotion. Now, we all knew that, you know. What's the first thing you said to your adolescent teenager when something happened? What were you thinking? Because they weren't. Because it was based on emotion. That's normal development. They're acting their age. Now, my kids, once I started teaching about this, would come back to me and say, "Well, Mom, you know it's my brain. It's not developed yet." I'm like, no. No. That is an explanation. It is not an excuse. Right? But again, using that information to help us see that there needs to be some direction that is given. Now, they still get to make a choice. You cannot force anybody to do anything. We want to. We'd like to. Doesn't work. But what it does mean is that they need to have that information to help to make that decision. And it's important that we give that to them. There are concerns, and here's where I think we have to be very careful. Because just as we hear a phrase and we automatically make an association about what that phrase is, right? People hear abstinence education and they make an assumption about that. True? You hear the term comprehensive sex education and you make a judgment about it, right? It's not all the same. And if you were involved in your communities and that is a part of what is happening, it is your responsibility as a parent, as a community member, to find out what curriculum is being used and find out what that means to the people who are teaching your children, if that's a part of what is happening. Because it is not all the same. And again, there are organizations that have helped, that have looked through different curricula, but I would still argue with you, until you see or hear how it's being taught in your school, you really don't know what's happening. And it may sound really good, but it may not be what you want your children hearing. Now, I also could argue that that's a great opportunity if you have a conversation with your kids, because they're being taught that, and you ask them to come home and tell you what they learned and then talk through that. Again, depending on what your situation is, what is required in your communities, what your government has decided. much of that is out of your control in some situations, right? But here's the concern sometimes that parents have. And I would caution you that this is not the case in all situations. Many times, what is referred to as comprehensive sex education fails to respect the role of the family in the community, and makes an assumption that the parents are not going to want the kids to have this information, and so the parents need to not know about it. And again, I think that that is dangerous. Excuse me. But you need to make sure what it is that they're talking about. Many times, there isn't really a discussion around a preparation for marriage. Again, sometimes there is not the value or emphasis placed on that. Many times, sex can be portrayed as normal with no significant consequences. And many times, abortion is discussed and not necessarily promoted, but discussed as a way to deal with an unintended pregnancy. And so again, you need to look at the curricula that is being presented and decide what that is exactly. Now, I would argue with you that we all want comprehensive sex education for our kids. Don't we want them to have education so that they can make a good decision? So if you take those words the way that they mean, I really want my children to have information, and I want them to understand why I think it's best for them to wait. I want them to have the full comprehensive amount of education. The problem is when you use this term, it can mean a lot of different things to different people. So I think we have to be careful about that. An alternative to that is something called sexual risk avoidance education, and I think it goes along with what we're talking about optimal health. But basically, again, you have to be very careful because it depends. There's a whole variety of these types of education that are out there as well. But basically, it is taught from a primary prevention standpoint, that youth understand that there are benefits to avoiding sexual risk, and that delaying the onset of sex is a real benefit to them, and that there seriously are benefits beyond just not getting pregnant or getting some kind of an infection. Because every adolescent growing up thinks it's not going to happen to them, right? That's also part of the developing brain. It won't happen to me. But there's other benefits that are involved with it, and that's important to be taught. I think there's hope and health, and it helps adolescents focus on a goal that they have in the future. One of the things that is important to recognize is that there are so many decisions that are made, and in most cultures it's between the ages of 15 and 25. The decisions that are made that then end up affecting you for the rest of your life, and the healthy choices you make in that time period will affect you the rest of your life, healthy or unhealthy. And again, as a public health approach, it's really important to have that conversation. The sexual risk avoidance education does align with behavioral health and public health goals. It does talk about a public health basis that prevents risks and behaviors, and it does prioritize optimal health. Some people say, well, is it working or is it relevant? And one of my favorite comments from people who talk with me, ask me questions about this, well, abstinence education doesn't work. Actually, what they usually say is, well, abstinence doesn't work. I'm like, well, it actually does work if you use it. But an abstinence education, you know, again, what is your final goal? If your goal for abstinence education is that nobody has sex until they get married, from maybe one class that they hear in 6th or 7th grade in school, pretty unrealistic goal. We have nothing else in our country that we ever attach that kind of a rationale to. If your goal is that the onset of starting to have sex or sexual delay is a result, then we have shown in the United States that that actually does work and is very effective. okay? And again, everybody has choices to make, right? You can give the public health message, and you can talk about what the healthiest choice is for them, and you can provide the options. But again, there's a personal decision that ends up being made at the end of all of this. And it cannot be one-time conversation. And it has to be reinforced by other people. You know, you can have this conversation at school, you can have it at home, you have it at church, your neighbors are talking about it. It's the way it kind of used to be back in the day, as my parents talk about that. But when you think about the society our children are growing up in, where else, what other kinds of messages do they hear that reinforces this as a health choice for them? They really don't, right? Media isn't giving them that option or choice. Movies or sitcoms or television shows they watch don't give them that as an example. If it's not taught to them anywhere else, there's no example for them to follow in that situation. So it's really important we look at that. What this study shows is that in 1991, when we actually started doing these studies and looked at high school students across the United States, looking at all sorts of communities, it's called the Youth Behavior Risk Survey. It's done every 2 years, looking at about a sampling of about 15 to 20,000 youth. And it's large cities, small cities, all across the country, rural, suburban, urban. And the question is asked, how many of you have had sex? And in 1991, the number of kids who had had sex by the time they graduated from high school, okay, was over 60%. Now, the latest one has flipped. So 61% of kids have not had sex by the time they graduated high school now in the United States, and that was 2017 data. So again, it's working. And that means that over half of the adolescents in high schools in America have not yet had sex. Now, if you look at the freshman in high school versus a senior in high school, there's a big difference there. The number of freshmen in high school across America that have not had sex is 82%. That's the age that most sex education is given, 8th or 9th grade. So what kind of a message should we be giving them if the majority of people sitting in your classroom have never had sex? We should encourage them to keep up with that healthy decision, right? Yes. Now, do they need to have education about how contraception works and why it may not work? And, you know, again, that has to be a community decision and a personal decision. I would argue that information is power. And there are great studies that prove that learning about contraception does not increase your likelihood to have sex. So again, the thought that, well, if we teach them about contraception, it's going to make them want to use it more, that's not what's making them want to use it more. Okay? It's every other influence around them. So once they know how it works or doesn't work, many times that's what it takes. Again, that is a personal decision. Families for communities for the United States, you as a country have to decide what you want to do with your country. But what I can tell you is that the message that needs to be given needs to be based on the audience you're talking to. If my educational program is aimed at 18 and 19-year-olds who are in my juvenile justice system, either getting in or out of prison or in and out of foster care, my message to them is going to be a little different than to my 9th graders, right? I still do the public health message, big picture. But then I look at them individually. Where are they? What do they need to do to be healthier? Whatever that step is. Again. Again, when we look at globally, sexual risk avoidance is relevant because when we look at countries, and this is probably too small for you to even see, but if you look across, these are a number of countries in Africa as well as Europe and Asia. But globally, for most nations, sex starts after high school, and in many places, it's after marriage. That is a normative thing in many countries across Africa. So the thing to remember is that when we're talking about this as a way to present information, that this is, if you just focus on preventing pregnancy, it's a sick care system. If you promote on promoting health and building assets and building protections to have a healthier life, that's what this is about, and that's what's important. And so it provides knowledge and skills, refusal risks. Again, somebody mentioned earlier today, self-control, self-regulation, very important, healthy decision-making. Takes into account the brain development of adolescents and helps looking at goals and helping to set future focus with education. Many sexual risk avoidance education curricula also have the added component of talking about contraception and talking about sexually transmitted infections and providing that information. It can be a part of what sexual risk avoidance is. Here's what the studies have shown us in the United States. If you have a conversation where you're giving basic knowledge, information about contraception and about sexually transmitted infections, but you are not providing samples of it and you're not demonstrating and talking through that aspect of it, there is no statistical significantly difference from kids increasing sex earlier than those who have had contraceptive education too. So it does not increase. The fact, learning about contraception does not increase the rate of sexual activity across studies. And again, that's a population study. Individual people may be different. Your community, you have to decide what's important for you. The other thing that is really important, and this goes along with the message, there are many adolescents that feel like, well, once I've started having sex, I really need to keep having sex. And again, what sexual risk avoidance helps with, and that whole model helps with, is to think, well, maybe not having sex right now for a while is an okay choice for you. Maybe the next relationship you jump into, maybe you don't immediately start having sex as a part of that relationship. Is that a possibility for you? And again, there's no other behavior that as a physician I would say to them, well, you've started drinking, you might as well just keep drinking. Right? Well, you started smoking, you might as well just now increase to 2 packs a day. That's not the way we approach behavior in a population public health message area. When we're talking about sexual activity, particularly for young adolescents, that should not be the way that we approach that message either. It should be helping them say, well, you may be sexually active, you may have had sex, but the healthier choice for you would be to wait until you're older to have sex again. And having it, that message or discussion that way. Because what are you going to do? I think, and I'm going to be very, can I be really frank here? Unfortunately, some of the most condemning places I have ever been have been in churches. And it shouldn't be that way. And so it's very important that regardless of choices that have been made, that there's opportunities for do-overs. Right? There's opportunity for starting again. If there's any place that that could happen, it should happen within a faith-based or church community. We should be the first ones to accept that and move forward in that situation. I think that many times the idea of pregnancy or sexually transmitted infection is not a deterrent. There needs to be a benefit of waiting for sex, to build healthy relationships, to look at, and there's so much data out there that looks at the fact that the younger you are sexually active, the more partners you had, the more likely you were involved in dating violence and other types of aggression and violence. It goes along with the pornography information we heard earlier today. We do have studies, contrary to opinion that you may have heard. There are studies that show that sexual risk avoidance education is effective in behavioral effect that lasts for a year or more. There's lack of negative effect and a positive impact on the entire population that is served. And I think you may have a presentation about this at some point during this conference that actually looks at data that shows the effectiveness of sexual risk avoidance education. Again, this is the reason why I do what I do. These are my 10 grandkids. Again, those of you who are here this morning, you saw this picture already. But again, the idea that what I want for them is health. I want them to live the healthiest life that they possibly can. Again, I know they're going to make their own. I wish I could make the decisions for them. I can't. But what I can do is give them information that will enable them to make the healthiest decisions that they have possible. So we have about, I think, 10 minutes maybe. And so I'm going to stop and see if there are questions that people have, and I'll try to answer them.
Thank you so much for your presentation. We truly appreciate, and we hope we'll get more time to speak to you after this event. I don't know if I got you correctly. You said that in America, before a curriculum is accepted and rolled out in the schools, the board and the community must agree on the content, and then it is rolled out according to their agreement. So I'm just wondering, this comprehensive sexuality education curriculum, in terms of its genesis, it means it was therefore wholeheartedly or maybe majorly agreed to by the board and the community, and then they realized it was a problem, and yet it is being aggressively pushed into the South now, into our countries. Is that the case?
I can't speak to specific instances or situations. What I can tell you is that there are a number of communities in our country that have chosen this curriculum to be taught to their kids. I think that you need to understand that funding and choices of educational curriculum, that is not mandated by the United States government in providing funding for people. So the people who are applying for funding usually talk about what curriculum they want, and if they win that contract to provide that education, then that's a curriculum they do. And again, I think that my personal opinion is that an NGO, no matter where they are from, being in another country is a privilege, and that should be agreed upon by the country and the people that that information is being given to before it is just given to them. So you still, we believe, have the authority. Your country certainly does, your government does. Whether or not you have that in your communities depends on what country you're from. But you should have the authority and autonomy to help to decide. The problem, and here's my caution to you, is there are many communities that say, no, we don't want the government to do it, but then the community doesn't do it either. So then the government kind of feels stuck because they feel kind of responsible, because then, you know, the information isn't out there. So I would encourage you as communities to make sure that if you're not doing it, that you step up and fill that gap. Right? Okay.
Thank you very much for the presentation. I imagine you put together your presentation from a public health perspective, which was quite nice. We have a policy we are putting together in Kenya, and one of the thematic areas is health. If you were to come up with and I want to take you back to when you, I imagine you came with the Trump administration to the health department. We're probably at that point, because if you look at our health ministry and what has been going on over the years, you'll find that the policies that are there are more anti or contrary to a lot of family values that we have. So if I was to take you back to the time you entered the department and you had to undo probably quite a bit of what has been done and create new programs, what were your 3 or 4 priority areas that you focused on? I don't know, you understand?
Okay, I do understand your question. And actually, there were not a lot of programs that had to be redone, because the options for sexual risk avoidance education as well as sexual risk reduction education have been available in the United States for a number of years. And so communities do change and do that. My responsibility is to make sure that we are studying those to see how effective they are so that then we can make recommendations for what should be used. But here's what we found. 10 years of study of a curriculum and then trying to take that curriculum and replicating it again in another population doesn't work. We have not been able to replicate a single curricula. 10 years. What that means is that you have to look at the population you have, decide what works for them and try to implement that, and it's components. It's not a whole curriculum. And so while the curriculum companies don't like that answer because they make a lot of money by putting a whole curriculum together, the reality is what science is showing us is that it's not one curriculum fits all. It's components of curriculum that work based on who you're talking to, the age of people you're talking to, what you're addressing, that tends to work. So we have data from probably close to 300 to 400 different implementations across the country, different age groups, different types of communities, and can show which ones were effective and which ones weren't. And it's on our website. And the components is what we're working on right now to say, okay, these are the components that work with this age group. These are the components that are important in this age group. And that's what I have been tasked with doing during the time I'm working there. But it's been around for a number of time. Now there's different things that have been encouraged different ways, and sometimes funding goes one way or the other. But we are very limited by what we can fund in America because of the laws. And they say, we are providing the funding for this, and we have to do that. Or we don't get it. So we don't get a lot of leeway back and forth. So there isn't as much change in that aspect of it.
First of all, I'd like to publicly thank you for an excellent presentation. I'm Sharon Slater with Family Watch International, and I'd like to publicly thank the Trump administration for their change in policy, because it used to be the U.S. government internationally was pushing comprehensive sexuality education, and that's no longer the case, and we're very, very grateful for that. And the other thing I wanted to bring up is there is, in the process of being printed right now, a new peer-reviewed study on sex education. I've got a copy of the basis for it. It's called Re-examining the Evidence for Comprehensive Sex Education in Schools. And I believe it's going to come out in about 2 weeks. And it supports a lot of what you're saying. It actually shows that the comprehensive sex education programs that were measured globally had an 87% failure rate, and it was an 89% failure rate in Africa, and that 24% of these programs in Africa increased sexual risk. So we're grateful for your message promoting sexual risk avoidance, because even though the data was more limited for the abstinence programs, this showed that it had a much better results, even in Africa. Thank you.
And I agree, and we actually were part of that study. Our department was part of that coming out, so I know that it's coming out. I've reviewed that data. It's very important, and I agree with what you said, but you have to look at what it means to fail. What the parameters were. To be honest in science, you decide what your measures are, and then your success or failure is based on that measure. So if your failure rate, if you were trying to say that you wanted to increase the use of condoms for the next year, that the people who had your education used condoms more than the people who didn't get your education in the next year, that's one measure. And if you didn't reach that, then that would be considered a failure rate. Maybe there was something else in that study that it did improve. And here's the problem with curricula, because curricula itself, we are showing this across the board. We have huge failure rates when we try to replicate it at different places. But there's components of it that work. So what we're trying to do is dig into the data here, pull out the components that consistently across the board, no matter what community it was in, seemed to give a positive effect of the measure we were looking at, and then look at those as recommendations. It's very tedious work to be able to say that. And I would also say that we have shown that it really doesn't matter what curricula you use, it's the training of the people giving the curricula that makes the difference in the results. Now that to me is not rocket science, we all know that. We know people that are better at teaching than others, right? But we now have proof that that's the case. And so the training of your people to give this is critical. However, what we did find in talking to adolescents was when kids are given a message that primarily says, this is what you need to do to have safe sex, the rate of increase of sexual activity does increase. And so if you're focusing on that, and that's what many of the curricula seem to focus on, there is a failure rate with that, and it's actually considered a negative effect because sexual activity increased. So again, it depends on what your community's looking at, what level you're at, what your success is. I have concerns about taking a comprehensive sex education and using that across the board. And that's just a research problem I have, because as a researcher, you have to define exactly what's in the word. Again, typically the same curricula were used over and over again because that was what was funded. And so you can find out what's in that curriculum and you can make that decision. But I think just as, I'll stop there.
Allow me to congratulate our presenter this afternoon. And one thing that I thank so much is the aspect that you're trying to bring, where the curriculums that you're trying to develop will resonate with the communities where they are coming from. Which brings me to the kind of approach that is value-based kind of education that we want to attain. And this will only be achieved by respecting even the cultures of people where we want to develop their lives. I want also to say that when this kind of curriculum, a comprehensive sex education has been introduced in our place, it was just in the coast region at Vipingo area. It's somewhere in the coast where about 50 heads of schools gathered as a result of kind of a thing. But eventually we sat with the teachers and asked them, what is the problem exactly? In fact, they themselves don't know how to handle that comprehensive sex education. With your presentation now, it has actually stepped up some kind of an intervention for our approach of things. And I believe with much kind of this kind of a platform, this kind of fellowship, this kind of exchange that we are having, we can learn from each other. Thank you.
Let me balance.
Yes, good afternoon. Yeah, my point would be, my brother has talked about sex education that was introduced in schools. Sometimes back in early in the year, in February, we wrote a letter to the Ministry of Education. We are proposing that we have what we call health education. Then we have topics like hygiene, sex, being subtopics covered under health education. Because we cannot have just sex education by itself when you don't teach the consequences, the points that have been raised on abstinence, and also other related diseases. Like right now we are having the challenge of the HPV vaccine. Most of us do not even understand here in Kenya. There was no awareness. We don't know what it is. Now, are we going to advocate as Kenyans for HPV vaccine or teaching our young girls about what sex is all about? Then with the representatives from the US government, why did the WHO and the other people bring to us the HPV vaccine? Well, we know very well it does not protect from cervical cancer. It only protects us from 2 strains of cervical cancer. Why couldn't you have sponsored health education or sex education so that we prepare these girls for what is taking place, the changes in their body? As we have talked about the development of pleasure centers when they are at the adolescent stage. I'm Emily Mkomunene, I'm an author, and I'm also an advocate for health education.
Would you like to respond?
Well, I'm an advocate for health education too. I think that the policy and the reasoning for the recommendation of the HPV vaccine is the incredible level of effectiveness that it has had in decreasing the incidence of HPV disease across the country that we've seen. And it does prevent against the 2 most common strains that cause cervical cancer. Those strains, there are 2 strains, but they actually cause 92% of the cervical cancer. So while it's only 2 strains, it does prevent the vast majority of the types of HPV that cause cancer. I agree with you that it can be a Band-Aid, and I agree with you that the conversation is the only way to avoid it 100% is to not have sex or to be in a mutually analogous relationship with an uninfected partner, okay? But we also know from a public health standpoint that not everybody's gonna make that choice. And also, while you might make that choice yourself, you have no control over the choice your future spouse might make. And in many cases, the vaccine may protect you from that in the future, regardless of the choices that you make. And so part of that is the rationale behind why it is a public health recommended campaign in America. And I think that most people feel like that if it is something that we are seeing such benefit for, that we should share it with other countries for that same benefit. Again, I think countries and families have the decisions to make themselves, but I also think you're right. You agreed, you deserve to have full information about it before you have, before you receive that. And whoever is here in the country doing that, whether it's USAID or World Health Organization or other people, they have that information for you. You just need to ask for that. But they have all of the data information of why that it's recommended. Does that help to answer your question? It may not be the way you want it answered, but I mean, I think that that information is there for you. You want to just ask it? Quick. We'll save time.
Considering that with the sole exception of barrier methods without spermicide, all contraceptives are abortifacient. Two questions. How do you reconcile that with your policy of not promoting abortion? And have you measured the behavioral impact of such a promotion in the United States?
What was your second question? Have we measured the what? Okay. Well, there is serious scientific disagreement about the fact that all contraception is abortifacient. There still is disagreement that all hormonal contraception are abortifacient. There is, but again, there is not scientific agreement from even pro-life scientists when they look at the data to show that. And again, so to answer that question, that is the reason why the contraception is available. There are forms that are certainly have been known
in the conversation didn't know that it was happening regarding comprehensive sexuality education. And by the time you hear about it, you're voicing your concern, but it might not be heard. So I have kind of concern there. And then I just wonder if you can also speak to, in the United States, there's $101 million that goes towards the sex education, or TTP, right? Teen prevention programs. Thank you. If you could just speak to that and how that is working.
Okay, as far as the SRA programs that are effective, again, it's the danger of taking sexual risk avoidance and then using that across the whole board. So the data that I'm talking about is the data that the federal government did in programs that we funded and we evaluated. And that's the reports that are effective. It's on our website. I can give you that information too. Yes, there are some other curricula that have been evaluated by the developers and all of that. Again, those are not the curricula that we report on or that we say are effective. That's not, when we're talking about this, we're talking about programs that we have funded in the federal government that we require evaluation on and that we report back on that evaluation. No, because again, like I said to you, it doesn't matter, SRA or CS, comprehensive sex education, when you take those and you try to replicate them somewhere else, we have no evidence that any of them work. Again, that study is probably going to come out probably next month, but it's a 10-year study looking at everything we funded for the past 10 years that we had to use stuff that had been shown to be effective, then we tried to replicate it in different places, and we did not get consistent replication. We found that the studies that were given only to girls were more effective than others. And the studies that were done in one-on-one setting as opposed to a classroom setting were more effective. That's it. Across the board, where we could consistently show effectiveness for any of them. Okay, so again, what that tells you is that the components that you pick and the community you pick, that's what's important in surrounding this. There are, again, individually, you can look on the website and see the number of them. I do not have the exact percentage of them because, again, there are way more programs than what we actually fund. So we don't evaluate those, and I can't speak to those. The second question, I don't remember. The third one was the $110 million, what I'm doing with it. I'm in charge of the TPP program. And we are following what the federal law tells us we have to do. We have two types of programs we fund. One that has already been shown to be effective, that then is replicated in another community. And what we are focusing now on are areas that are showing a higher percentage of kids who are sexually active that are outside of the norm of what I showed you for our norm for the United States. Of the number of kids sexually active, so we're picking areas of the country that are showing kids being more sexually active and implementing programs there to see what may help with that. And then the second aspect that we fund are brand new programs that have never been evaluated, to evaluate those programs. And that funding announcement is going to come out in the next, they're working on it while I'm here, and so it should be ready for me to review when I get back, so it'll be a funding announcement for that amount. It's a 5-year grant program for our TPP program that should be coming out very soon. And your middle question was what? Okay. Okay. Do we need to move to the next session? I don't want to take time away from Oh. That's where your vote works. Okay? If your school board is not doing what you want, you don't vote for them the next time they come up for election. I mean, that really is your only power as a community, right? I mean, it is community driven, and if your school board is making the decision, you elected them. So I mean, there's not really anything to do, but I agree with you that in some situations the school boards are not reacting the way parents want, but the only thing you can do is elect school board members that will do what you want them to do.
Two very short questions regarding the HPV vaccine and the hormonal contraceptives. With regard to HPV vaccine, here now in Africa, we are having so much confusion. Even last month or the months before, it was being implemented in Kenya, and I read about a huge uproar in the community regarding its implementation, because there is so, I mean, there are people who are coming out saying they have enough evidence, research-based, that it causes infertility and things like that. And there are parents who are refusing to have their kids getting them vaccinated with, and now the additional thing that's coming up is boys are also being told to take the vaccine in some nations. So, I mean, there's so much confusion. I just want some clarification. Is HPV vaccine being given to young people in the United States itself? Is it being implemented? And is the confusion around this vaccine
So I wonder if informed consent is respected in this vaccine. And also, there's also the niche effect that hasn't been studied because it takes decades. Like maybe another virus strain from the HPV can take the same niche that the vaccine supposedly covers, so the epidemiological total effect is 0. So I'd like you to comment on that. And about the abortifacient effect of hormonal contraceptives, even the package leaflet says it has an abortifacient effect. It says, it talks about the thinning of the uterus, the anti-implantation effect. So do you respect informed consent and tell the students that, okay, even the package leaflets, so there's no argument about that. It's not that one scientific argument against another one is even in the package. So, and I was wondering if you tell students about that, what's the reaction? Has it been measured that there's a probability they are killing their own children without even knowing? Thank you.
Thank you for your presentation. My name is Sister Rose Macharia, Sisters of Mercy. I encountered comprehensive sex education about 2010 in Lodwar, that is Turkana County. It was being pushed by a particular NGO, and that's when I came face to face with it. And for sure, from an African perspective, they were teaching what was not appropriate for class 5. But now my question is, or my concern, here we are, because we are having a conference and the other conference is going on. What are we doing, especially about our school children? In the primary schools here in Kenya, from the Catholic side, we have the Making Life Responsible Choices. But for secondary schools, everyone is doing their own program as much as possible. We do not have a curriculum that is helping all of us. When we go to meetings and we find the abortionists and those who are pushing for contraceptives, they tell us then, if you don't give that girl from the slum the contraceptive, she's going to become pregnant and drop out of school. What alternative do you have? So my concern is all of us together. What is the alternative? You're doing the SRN in America. There are other maybe curriculums that are happening elsewhere. But the funding that is so much there for the comprehensive sex education, how come there are no like-minded people to counteract that and give our children something that is valuable, something that is going to give a dignified life to the young ones, and as you said, to the 3rd and 4th generation? I don't know whether we have any answers.
Thank you. My name is Honorable David Sudi, Party Leader, New Democrats. Thank you for your presentation this afternoon. We have seen that there is no solution to what we are facing now. But I've come here to suggest that we as a body of Christ, let us refrain from sexual activities, because what we are doing by doing research and everything, there is no solution to it, because definitely there is no assurance that our girls or wherever will conduct disease. There is no, will not conduct, whether it is a vaccine or whatever, it may even accelerate getting that disease. So I'm not seeing any solution to this. Let us see how we can empower these people without worrying about what will happen in terms of whatever. We tell them, refrain from sex until you are married. That is when you can have a family. But when you tell us we are giving you condoms and this, you are encouraging people to get exposed. So me, as a party leader, I'm encouraging my members to refrain, and I'm empowering them to get resources so that they can do as per what the Bible says, because the Bible says, "My people perish for lack of knowledge," and we're really perishing. Even you claim to be a Christian, but you find that you are the one who is doing all these things, messing up and giving you problems that we are sick. What are you doing as a government? Yet you are the one who looked for this problem. My people, let me tell you one thing. There is no solution. The solution is to refrain. Tell our children, let us refrain. There is no one who has died because of lack of being sexually active. No, there is no record about that. So let's refrain and let us do. Thank you very much. Otherwise, Salamia Trump.
He says, "Greet Mr. Trump." That's what he said. Yes, I now starting from here.
Thanks very much for that excellent presentation. Will we be able to get access to this via email, or to get access to this excellent presentation? Will it be possible? 710. You send it to us via email? Oh, okay. Yes. Okay.
Okay, but it's okay.
Yep. So I agree with you about the primary role of the parents, and there's some people from Uganda. We're very proud of what President of Uganda said yesterday. He said that much as they were talking, he's on the ICPD25 side. He said much as people are talking about my body, when you own something, even an enterprise, you do consult, isn't it? Yeah, you do consult, and you should consult with elders and people who are more experienced. And the primary role of parents cannot be abdicated to teachers. It cannot be abdicated to anybody. As a medical doctor and as a mother, I really try to make sure I talk to my children about these things. I used to tell them about how the safe sex is just a myth, and the contraceptive rate, failure rate of condoms was up to 30%, and would they enter an aeroplane which had a 30% engine failure rate for HIV transmission? So as my generation especially, I find that many of us, we made a lot of mistakes and we had consequences for that, so they feel that they're not authorized to talk to their children about these things because they also made mistakes. But I tell them that is precisely where your authority lies, because you say, yeah, I made these mistakes, I'm not proud of them, and you be open with your child. That is a very good testimony to the child. Yeah.
Thank you very much.
Thank you very much for the presentation. Extremely insightful. But truth be told, the side event is about pro-family. Pro means that there is a God at the center. The reason why we are pushing the natural family is because we want to respect what God places value on. The cultures are different. What works in the West may not work here or will not work here. So all of this is good. Research, findings, and all of what we're talking about is excellent. But I think this pure solution to all this is, let's get back to family values. Let the African government, it's not about, thank God for your government, you're doing so much. But before we get to that place where we lose it all, the leadership of Africa must come together and be able to speak with one voice on what works. Because the dynamics of effectiveness in the US will not be the same dynamics that will apply here. And then there are other indicators that vary from both cultures. Poverty is a serious issue here. And most of the people that probably indulge in sex before marriage, some of them is because they want their ends to meet. They push children into. So there are so many factors. But truth be told, let us get back from here and get back to arming the younger generation with the message of abstinence. the summary of all, whether it's social studies or social science data, research and all of that, is compounding problem. The solution is very easy. Abstain. Abstain. Why do we belabor issues? I talk because I'm from Ghana coming. I work a lot with families. I work with churches. I work with institutions. I work with the younger generation. I work with all manner of people. And I've come to realize one thing. The fear of God is the beginning of wisdom. I stand here over 50 years, getting to my mid-50s, with 4 adult children. And I tell them, things were not even as bad as they were. But I, as a person, made a vow concerning my body, that there were certain things I wasn't going to compromise with. And I can look back 50-something years, and I'm proud of the decision I made. You said something very strategic. You said the brain is not formed for the young people until they get to about 25 years. So most of the decisions they make is based on emotions. So why would the parent not take responsibility of praying over the children that they will listen? And number 2, the government also legislating certain things, because the influx on internet, there's a lot coming. What worked in my generation may not work now, because the dynamics have changed. The children have access to all manner of information that is not really very positive. So I will encourage every leader who is seated here, whether religious leader, political leader, civic leader, whatever leader. Let us, at the end of the day, when our guests are gone, let us sit on a round table. Let us sit on a round table and decide what really will work. Even with the curriculum in school, the curriculum should not be imposed. I don't understand why, as a black, anybody will think my brain is not working. My brain works. And so I should be consulted when issues that need decision making are about to be taken. With regards to my children, I should be a stakeholder that decides on what works. And until I give a consent to what works, nobody should impose their will and their mindset on me. And so let us summarize all this grammar we are speaking. The grammar is not going to take us anywhere. We have done research and findings, it's fantastic. But at the end of it all, the person in the community is not going to be understanding whatever the English we're speaking. The only English we'll understand is at the grassroots there, that the chiefs and the custodians of power in the grassroots have certain organizational or certain setups where they teach the people in the community what works, and then at school and all levels. But summary is, please, if you can answer the questions, God bless you. If you cannot answer, pray for us when you leave, that God will help us.
Please keep the grammar brief.
Thank you so much for giving me a second opportunity. I'd urge you, because you know there are resolutions we're going to come up with. We've had all these very disheartening things about HPV. But this is not something that parents or the community have been given a choice in Kenya. You have mentioned that in the US it is a voluntary exercise. People get up and choose to go for the vaccine. That is not the case in Kenya. It is already being rolled out in schools as we speak, to primary school children. And I don't actually remember that there was even public participation in terms of choosing, like she said, that this should be done. Was there public participation? So I'm urging you, because you have spoken about time lags, we cannot wait for you to go to President Trump, especially because you're closely working with him, speaking to him, and then getting him to speak back to our government to make a change. There will be a dangerous time lag. It is already being rolled out in our schools. So I'm urging you, please, before you leave, can you kindly, working with this team that's coming up with the resolutions, impress upon our government leaders, the president himself, before you leave, because you represent your government, President, if there's a way in which you can at least let them know that you have understood that there was no public participation and agreement on this HPV, that it is not a voluntary exercise, that it is not recommended even by the US government, and that maybe it should even be arrested and reconsidered with public participation before it continues being rolled out in schools. I think if there's a way you can do that for us, that would be very, very useful.
finally,
Thank you. What is your name? Right here. You need to go across the street and talk at that other conference. Dr. Foley, thank you very much. I mean, it was really a wonderful presentation. The U.S. now, I think, spends about $700 million a year, maybe a little bit less, in family planning internationally. And I believe most of that is commodities, is it not? Okay. My question is, well, first of all, across the street, they're saying that that's what all you African women want. Just to let, that's what they're saying. My concern is on a specific contraception, the Depo-Provera, which you know is quite controversial. And we were in touch with a WHO researcher who was with the WHO at the time when the Depo was developed. And he said that it was never was meant for adolescents due to the bone density loss risk. But yet I know we are promoting this among adolescent youth as well. So is there anything the U.S. is doing now as far as informed consent to make sure that this doesn't get directed to adolescents and their health is not impacted?
so we need to let her respond now. Whatever you can. Okay, it doesn't have to be everything, just what you can, and then we move on to the next session.
I was going to say what you said. Because here's the thing, it doesn't really matter. I can't answer these questions for you, but you have the power in this room to answer those questions for yourself. I mean, this is not, first of all, I want to say that the policy of this administration is that each country has the autonomy to be able to decide for themselves, and that truly is the case. Now, what you need to understand is not everything that comes from the U.S. comes from the government. You understand that, right? There are a lot of private companies and private foundations and private NGOs that are a part of this. So some of the stuff you are talking about, I have no idea what you're talking about. However, I'm a very, very small, very insignificant part of the huge thing that is the government. So again, I can't speak to those things specifically. What I do know is that if human rights are the issue, then you need to stand up for your human rights to be able to have a say about what happens to you. And I can't do that for you, but you can do that for yourselves. And so I think that's what's the most important thing from this standpoint to come as a result of what we're talking about here. I think that I don't know who is doing the HPV vaccine over here. I don't know that it's the U.S. government. Do you all know? Is it World Health Organization? Okay. So that, again, is not the U.S. government that is doing that. And so we don't have the authority to be able to stop that, but that organization is very big on human rights and individual rights. And so, you know, you as a country, as a group of people, need to be the ones to speak up and say, no, you know, that we didn't have an opportunity to make this decision or whatever. I am not here. Yes, this is recommended in the United States, but that doesn't mean that you have to accept it in Kenya. And that's not what I'm here to do. And so, again, I also have nothing to do officially with global work. I'm stepping in for the global people because they were doing something else. I'm familiar with it and I can speak to what their policies are. But again, we are willing to take individual questions about specific projects and I can deliver those questions back to the global people who are actually responsible for them and can get a response, to you. So the specific questions that you have, again, aren't government policy. It's not something that I'm coming here and telling you that you have to do. It's presenting information and also presenting what our domestic policy is. I agree with you that it is very disrespectful to think that what might work in the United States would for sure work here. And I think it is disrespectful that curricula are brought that have not had any input from people on the ground in that culture to be able to do it. The diaspora that is in America is used a lot to make some of this curriculum, but again, because they haven't lived here for a while, they may not be, there's attempts made to make it culturally appropriate. But again, it doesn't always work that way. And I agree with you that you need to be able, as a country, as an individual community, to make those decisions yourself. But that's also something that you have to do that I can't do.
And you need to keep clapping until she sits down in her seat because she's worked really hard. Thank you very much. Keep clapping, keep clapping. Tashkuru. So good people, you've been seeing me around here running up and down, but my real boss is Dr. Wahome. Okay. He's the man who has been calling the shots, and he's the convener of the Life and Family Committee of Kenya Christian Professionals Forum. And when the alert was made, he asked me, Richard, can we put something together? And we assembled what we have here. One of the things we've been struggling with, the basis upon which Kenya Christian Professionals Forum was founded, was concepts in our constitution. We were asking the committee of experts to remove certain phrases from the constitution that would lead us to the dilemma in which we are, and the committee of experts did not listen. So we chose to oppose the constitution, as the bishops had advised us. The bishops had advised us not to vote that document. But anyway, as usual, sometimes we fail to listen to the prophets, and the result is that we face the consequences. It is not yet 10 years, and you see what is happening, that Kenya is being used as the best case scenario where this stuff has to be demonstrated for Africa. If we had listened to our bishops, probably, it would be different. Now, you heard the president's statement, and you realize he still maintained that word, reproductive health care and rights. When we were trying to influence the government document, we could not plug out reproductive rights. Why? Because it is in our constitution. The technocrats were saying, but this one is in the constitution. Sexual health, that one we can leave out, but reproductive rights is what? Is in the constitution. So we need to be alert to what is going on. Dr. Wahome has spent some time thinking through the definitions that matter, and he's going to share with us before we read our declaration. We have drafted what we've called the Nairobi Declaration on Life and Family. And that is going to be our closing declaration. Even though there is no other media house here, we will document ourselves on the YouTube channel. And there is another presentation from Christian Voice, you said? Yes. We will announce it at the end of the declaration. All right. So let Dr. Wahome go on.
Good evening. I know it has been a long day, but we came for a purpose. And there are things that we need to cover and ensure that we live here with a very clear mind and a very clear roadmap. So I'll be talking about the definitions that matter in healthcare from a Christian perspective. It has been clear that now we must declare our stand we are going to discuss this from a Christian perspective, and we are not going to apologize to anyone. Now, my name is Wahome Ngare. I am the husband of Mercy. I am the father to Ngare Nyingi and Gadhoni, and I'm a child of God. I am a gynecologist by training, and as you've been told, I'm the convener of the Life Committee. I have a lot of slides. Unfortunately, we've lost one screen. The diagrams. So let me quickly go into this. Human rights, health, and Christian values. Why should we be concerned? The definition of health and human rights in our faith affects the following things. It affects the dignity of the human person. When we are talking about transgender people, people who have gender dysphoria, and who are being encouraged to mutilate themselves in the name of rights, then we really are abusing their dignity. When we have a right to life, and we have people who are advocating abortion and euthanasia, then again it is a threat to the right to life. When it comes to family and marriage, then contraception, homosexuality, and divorce basically affect our marriages. And when it comes to relationships between our parents and children, the fact that comprehensive sexuality education is teaching that children can have a different opinion from their own parents is in itself a major problem to our faith, because we are trained, or we train our children to honor their mother and their father. These are the people who are the first teachers. These are the people who know what your culture says. These are the people who hold your faith. If somebody comes between you and your child and tells your child that they have a right to have a different opinion from you, then that is really destructive to family life. And finally, as Catholics, we do not expect to recruit any more nuns or any more priests if we are going to have sex for pleasure from the age of 4. Okay? So comprehensive sexuality education is obviously a problem. Now, there is this diagram that is called the life cycle, and I chose the life cycle of a chicken because of the issue about evolution. Now, between the egg and the chicken, which came first is what we are asked. And if you say it is the egg, then you ask, where did it hatch from? If you say the chicken, then you ask, where did the chicken hatch? You know, so who laid the first egg if the egg came first? And if it was the chicken that came first, where did it hatch from? And you can have that discussion the whole day, and we will never agree, isn't it? So when we use this type of life cycle, then what we are saying is that it's not possible to determine how life began. All right? And that opens the door to evolution. Okay? But there is something wrong and very deceptive about this life cycle, which is what we were taught in school, which is what is still taught today, is the fact that there is no male. Are we together? So long as there is no male, this egg will never be fertilized. And if the egg is not fertilized, you will never get a chick. We have been told alive for a long time that reproductive health is about woman's health. But the woman will never reproduce without the man. And the minute you remove man from the reproductive equation, then you create an imbalance that is not healthy. Once you put the cock here, then you must believe that the male and the female were created and were present from the beginning for any human life cycle to continue. And therefore you must believe in creation. Are we together? So we have been lied to too long, okay? Now, the other question is whether there is a God. And our children are being told there is no God, and they're being told they're stupid for believing in God. And because of evolution, then it becomes tricky for them. Some of our own parents cannot explain this. So the question then, is there a God? Is there a God? Why do you believe in such stories? Because you know, and you feel, and you've experienced. But I have never experienced anything like that. You say it is in the Bible? I don't believe the Bible. So, that's a good one. I see creation. So, let's find out if there is a God. I was conceived by a woman and a man, and I started a journey called life, right? After birth, the most difficult thing I have to do every day is to make choices. True? So inside your heart, whether you believe in God or not, whether you are traditionalist, Christian, or whatever it is you are, you have a conscience, a little voice in your heart that tells you that what you're doing is right or what you're doing is wrong. Isn't it? The conscience is inside of you, and it is independent of your religion. So where did it come from? Okay. We are going to go through death. I have been unfortunate to witness death. And anytime you witness death, you believe something left that body. 1 minute I am with a woman who's complaining of chest pain. She's just come from surgery. And then the next minute she's not breathing. We are calling in the emergency team. We are resuscitating. And 45 minutes later, I'm writing her death certificate to say she is dead. She is to be taken to the morgue. What just happened? I was talking to her 45 minutes ago. And now I've written her death certificate. She is to be taken to the morgue. If we keep her in the ward, she's going to rot and smell. So what happened? Something left, isn't it? And when we go to bury, we say we are burying the body of so-and-so, isn't it? Something left. So the concept of the soul that is eternal, that doesn't die, is not a Christian concept, isn't it? It is found in almost every religion you can find, okay? So if the body separates at death from the soul, then the two must come together at conception. Just makes sense, doesn't it? So if I was conceived, then I must have a father and a mother, isn't it? Even if I don't know them. And if I go back to my father, to my great-grandfather, I come to the conclusion that there must have been a man and a woman who were not born by anyone. And they must have been present at the same time to start the human life cycle. True? Where did they come from? There must be an answer to that question, isn't it? And they were eating the same things I eat today, so that the whole of the physical environment must have preceded them, isn't it? So the plants and the animals must have been there before man came to be. Otherwise, what would he eat? True? And if the plants then existed, then there must have been water and the sun and everything else. True? So all the elements and the soils must have been there before life began. Then the question is, where did they come from? So we come to the conclusion that there must be one who is, who was, who always shall be, meaning they are eternal. And that they existed before any physical matter existed, then means that they must be a spirit. And they are greatly powerful, that they created from nothing and created everything that we see today, isn't it? And that they put in me a conscience. And there is something wrong with my relationship with them because I'm not consistently able to make the right choices, isn't it? So why do I believe there is a God? Because I can see the physical environment. So long as matter exists, it must have come from somewhere, isn't it? I believe there is a God because I have a conscience in me. I believe there is a God because of the separation of the body and the soul, and that there is a fracture between my relationship and Him that must be corrected. Now you can open your Bible, and the Bible says, in the beginning, God created the heavens and... So even the Bible assumes you are intelligent enough to have found God first. The Bible doesn't justify God. It only tells you who He is. Are we together? Very good. So we have sorted that out. There is a God. And the atheists need us in order to define themselves. There must be somebody who believes in God for you to define an atheist. Isn't it? Now, when it comes to human rights, and this is where I would like us to pay a little attention, as Christians, God has given us gifts. He has given us certain gifts as humanity. And when you look at those gifts, then those gifts would then become what God has given me, you have no right to take away. So we are created body and soul. And when it comes to the body, then he gave us the right to human dignity. We must be respected for being just the creation of God, created in his image, isn't it? So I have dignity, and you cannot take it away from me. You need to respect it, okay? When it comes to the soul, then remember that the gift we are given here is the right of choice, the freedom to choose, the free will. That's the gift God gave us. And everybody has that gift, isn't it? Yes, nobody can take it away from you. The next level of development then is the community, and God gave us the right to reproduce so that we can have families and we can have a community. Then the next level, he gave us the environment, the physical environment, and he gave us the right to exploit that environment so that we may find food, shelter, and clothing. Does that make sense? So we have 4 rights that I have extracted from our faith: the right to human dignity, the right of choice, the right to reproduce, and the right to exploit our environment. Now, as Christians, then we don't believe you have rights that are exclusive. We believe that God also gave you responsibilities, because choices have consequences, and you shall be held responsible for your choices both here and eternity, isn't it? So what responsibilities were we given when it comes to the right to human dignity? We are given the responsibility to protect dignity. We have to protect human dignity. It is our business to protect the dignity of the other person. When it comes to the right of choice, then it is our right, it is our responsibility to seek and impart the truth. You cannot make good choices unless you have been given the truth. So it becomes your business to seek the truth and to impart or speak the truth. When it comes to the right to reproduce, then we were told our responsibility is chastity and stewardship. That you must understand the place of sex to be in marriage, and that marriage is going to be fruitful, and that those children are your responsibility to bring up in the fullness of the knowledge of God. All right? When it comes to the environment, then there is social justice and what we call sustainable use. Don't abuse the environment. The environment actually doesn't need you. It is you who needs it. It is your responsibility to care for the environment. So, social justice, you understand that the world belongs to all of us, and nobody should go hungry when you have food in your house. Just because you own the piece of land doesn't mean your neighbor should go hungry. There must be an element of social justice. And then sustainable use. You cut down a tree, plant 2. Remember the usual? So those are our responsibilities for the gifts that God has given us. Now when you come to health, which is where our crux is, WHO goes on to define health as a complete state of physical, mental, and social well-being, and not merely the absence of disease or infirmity. This is what they defined it at the onset in 1948. We are saying this definition is defective, it is incomplete, and we want to challenge it. So let us see, when it comes to the right to human dignity, then we are basically talking about physical wellness, isn't it? So in that sense, we agree with WHO, they have physical. When it comes to the right of choice, we are now talking about spiritual wellness. Your spiritual wellness is determined by your foundation of decision making. What is your moral foundation? What determines what is right and wrong for you? Because that is what will determine whether you are spiritually well. Let me give you an example. If I am a married man and I am having an affair, and my son is 16 years old and he knows about the affair, but the mother doesn't know, and he's torn between whether to tell the mother or not, I have scandalized my son, isn't it? Because of my spiritual illness, I have scandalized my son, isn't it? And what happens to that child? He starts abusing drugs and starts doing all sorts of things, and I take him to the best psychiatrist. Isn't it? I say my son is sick. So my spiritual illness has caused mental illness in the son. Okay? Are we together? That is how it works. So my spiritual illness can impact others through scandal. So spiritual illness is about seeking the truth and making decisions that are based on the truth. When it comes to reproduce, then we are talking about family wellness. You cannot talk about reproduction without a man and a woman. And you're saying each baby will require 18 to 24 years of care before they can be independent of the parents. It is only sensible that the relationship that brings in that child into life is permanent. Because if I get married at the age of 30 and I finish my first project at the age of 25, I mean, I'll be what? I'll be 50? By the time I finish with one, by the time I finish with the last born, I should be retiring. So long as you reproduce, then let it be within the family unit, and the family unit is made of a man and a woman, and it is the smallest element of the society, smallest unit, isn't it? So mental and physical basically mean the same thing, so we'll leave the mental there for WHO so we don't argue too much. But social, we want to bring it down to the family unit, okay? So that we talk about family wellness. And when you come to the environment, then obviously there is environmental wellness, isn't it? So the definition that would work for us as Christians then is that health is a complete state of physical, mental, spiritual, which they skipped, family and environmental well-being, and not merely the absence of disease and infirmity. The key here, ladies and gentlemen, is that the minute they removed spiritual well-being from the definition of health, they locked out spiritual leaders from any discussion to do with health. And yet I've just demonstrated to you that mental illness is a consequence of spiritual illness, okay? So we need spiritual well-being back into this definition. So if you then go to the Declaration of Human Rights, there are about 30 articles, and you look at them, you can actually place each one of those 4 rights on each of these things that they have recorded here, all the way up to 30. So for us, those 4 rights cover the whole of the Declaration of Human Rights from our perspective, okay? So that takes care of the definition of health. Are we still together, or people have slept? Okay. When it comes to the definition of abortion, it is the most mischievous you'll ever find. I looked around, and everybody defines it differently. The termination of a pregnancy after accompanied by, resulting in, or closely followed by the death of the embryo or fetus, you know, that's just one. There is this one that says abortion in medicine. An abortion is the premature exit of the products of conception, the fetus, the membranes, the placenta from the uterus. It is the loss of pregnancy and does not refer to why the pregnancy was lost. So why were you defining it in the first place? Okay. Then there is this one that says medical abortion is the use of medicine to end an undesired pregnancy. The medicine helps remove the fetus and the placenta. Now, ladies and gentlemen, basic biology tells you that if you have sex, it is true you may experience pleasure, but that pregnancy is a natural outcome. As a gynecologist, if you come to me and you are having sex and you're not conceiving, there is a problem, isn't it? When you conceive, then it is normal, isn't it? So when you come to me and you say, "Doctor, I'm shocked, I'm pregnant, and I wasn't prepared," I simply ask you, did you have sex? And if the answer is yes, then you really don't understand your biology. There is something wrong. So you can't say it is undesired, unintended, so long as you had sex, okay? So that one is there. Then there is another one that says is a termination of pregnancy before the fetus is viable. So before the fetus can live outside of the mother. Who determines viability? Who decides whether this baby should be terminated before or after? So when you come to, this is another one from Wikipedia, basically they are all incomplete. When we come to our big brother, WHO, they define unsafe abortion, and they say it is a procedure for terminating an unwanted pregnancy either by persons lacking the necessary skills or in an environment lacking minimum medical standards, or both. It's quite a mouthful, isn't it? But this definition does not mention the mother. It doesn't mention the baby. It doesn't tell us whether the baby is alive or dead. It doesn't tell us which method is used. They are talking about the qualification of the person and the room where he's doing the operation from. Are we together? These definitions do not help us, and they are so many and diverse. So why don't we help them? All right? So the deficiencies in their definitions: was the loss spontaneous or induced? They don't tell us. Was the baby alive or dead? They don't tell us. Can the baby survive outside the mother's womb at the point of termination? They don't care. Was a pregnancy a medical disease? Now here I'd need to explain a little. If a pregnancy is in the tube, then it is a disease, it is not normal, isn't it? So when you go to remove that, it is not an abortion. It's basically an operation to save the mother's life. So is a pregnancy a disease? So that is one of those. Is a pregnancy causing the medical disease? High blood pressure caused by pregnancy, okay? What is the intention of the mother in seeking the termination? They don't tell us. What is the intention of the person terminating the pregnancy? Again, they're silent. What method was used to terminate the pregnancy? So if a mother is pregnant with severe high blood pressure, she is 28 weeks, I can go and do a cesarean section and deliver a premature baby with the hope of saving both the mother and the baby. Or I can inject the baby and kill it and then induce labor, isn't it? True? So what is my intention and what method did I use? So those are not clear. So what we are suggesting is that we define abortion simply as the deliberate killing of a preborn person. Period. So if the baby is alive and you kill it before it is born, then that is an abortion, isn't it? So that if a doctor is terminating a pregnancy where the baby is already dead, it is not an abortion. Whether this baby is 5 weeks, or this baby is 30 weeks, or is 1 month to delivery, it shouldn't again matter, isn't it? So that is what we are suggesting for us would make sense. It clearly covers the intentions and outcomes. It does not matter the age of the pregnancy. It does not matter if the baby is normal or has defects. Remember, a child who is abnormal in the womb is not an abnormal pregnancy. So the baby doesn't have hands and legs. It is not an abnormal pregnancy. The pregnancy is normal, is growing well. The baby has a physical disability. You have no business killing it. Okay? So, does it matter if the person is trained? It doesn't. Whether you call it safe or unsafe, so long as you kill the baby to terminate the pregnancy, then you have committed an abortion. So it is a total waste of time to call it safe and unsafe and make us even have a debate on the same. Okay? So that's it. And when it comes to our constitution, basically, as Kenyans, we find abortion is written in our constitution. And if you have understood how we have defined it, if abortion is the deliberate killing of the preborn person, then the law says it is not permitted, unless in the opinion of a trained health professional. Now, there is no health reason that would make me kill a baby deliberately. That is why this term is very deceptive. I cannot give any medical opinion of why a baby should be killed deliberately. Okay? So, then they added here, or permitted by any other law, and that's what they have been trying to do all this time. So, this term needs to be defined so that we are able to argue our case about how to read that concept. Then finally, about gender dysphoria, same-sex attraction, and prostitution, Sigmund Freud told us that childhood events have a great influence on our adult lives, shaping our personality. And he says, for example, anxiety originating from traumatic experiences in a person's past is hidden from the conscious and may cause problems during adulthood. Okay? These are mental illnesses. What my son suffered, as I explained to you, isn't it? When you see people who cannot tell whether they are male or female, people who are attracted to the same sex, people who are prostitutes, these people are people who must have suffered very great trauma in childhood. That you could actually, our business is basically to love them. They are going through a very major challenge. We support them, we love them, and we help them with support so that they can get healed. When you normalize this behavior or encourage it, or even go to the point of preventing its treatment, you are being very cruel. Very, very, very cruel. And I think it is time we stood our ground and said, it doesn't matter even if the American Psychiatric Society redefines the definitions of these terms, it will not change the fact that there are two sets in the LGBTQ agenda. There are patients who desire treatment, who need love and care, and there are advocates who want to normalize an illness for their own selfish needs. Okay? So in conclusion then, we define health to include spirituality, the family, and the environment. We clearly define abortion. And then we say that our people with gender dysphoria, same-sex attraction, and prostitution, these are illnesses. These are people who need love and care. And we should be able to take care of them so that they can reach healing. Thank you very much. Unless there are any questions, it should be quite straightforward. Can you? Yes, yes, sure.
Thank you, Dr. Wahome. You may not know this, but I'm one of your admirers. Because if there's anything I detest in life, it is contradiction. And you see, the principle of non-contradiction says that nothing can be simultaneously an orange and a lemon at the same time. You're either this or that. And you see, most lies thrive on contradiction. You know, double speaking. And the pity is that many people are so gullible and actually swallow the lies. Now, having said that, I agree with you perfectly that many of these people who find themselves, you know, who define their existence by sex or sexual behavior, you know, it's pitiable. And really, like McHugh of Johns Hopkins University has said, what they need is treatment, not encouragement, but treatment and understanding, you know. I often make a distinction between two concepts which ties in with everything you've said, and that is predisposition and predetermination. Predisposition is a tendency towards such LGBT lifestyle. So there could be a tendency, there could be a predisposition, which you said could be as a result of trauma suffered, and I think Sharon has an excellent CD on that, on same-sex attraction. I don't know if it was shown. Was it shown at all? It wasn't shown. Oh, we missed out on that because she has an excellent CD on understanding, DVD on understanding same-sex attraction. It's on the familywatch.org. I think everyone needs to see it because it actually explains a lot of things to you. So yeah, the predisposition could be because of environmental factors. Now, predetermination is the argument that comes up from people who say it's genetic. And like the young chap told us today, in music it's there, you know, like all the singers, what's her name now? The crazy one, can't remember? Gaga, Lady Gaga, she will tell you I'm born that way, you know, and everybody's singing born that way without even thinking of what they're saying. But the fact is, now, let me make a point here. Even if somebody is born that way, can the person struggle against such?
Because people who are kleptomania, you know, the kleptomania are people who still have this tendency to steal. It's a tendency anyway. Or people who are diabetic. That's something that is genetic. That diabetes is genetic. Now, if you are diabetic, do you just settle for it and say, that's the way I'm made, that's the way I'm born, and then you go eating all the sugar and what have you? You make an effort, isn't it, to prevent your health state worsening, all right? So I think doctors, thank you for always telling the truth. Doctors need to tell the truth. WHO is compromised. They need to tell the truth. We need to hear more about the side effects of contraception, the side effects of all this lifestyle, what happens when people engage in this permissive behavior. And Dr. Ome, thanks for the introduction you started off with. Because at the end of the day, some people will say, hey, it's because you are religious, it's because of your faith. It's not a matter of faith. This is what Bernard Nathanson, an atheist, told us when he came out with Silent Scream after starting the largest abortion clinic in the United States. He says, it's not a matter of faith. It's a human question. And Dr. Wahome started off with faith by showing how faith conforms with reason. Faith is in perfect conformity with reason. Faith is reasonable. And when we choose not to do the right thing, what God tells us, I mean, we destroy ourselves in the process like a snake that consumes itself. So thank you for your excellent presentation. I think it's a very good way to end today's exercise.
I just wanted to give a personal example to support what Dr. Wahome just presented to us, and I too am an admirer of him and the great work that he has done. When I was pregnant with my 4th child, I was about 7 weeks short of full term. I went into a seizure. I had preeclampsia, and they told me, in order to save your life, we have to deliver the baby. Now notice, they didn't say, in order to save your life, we have to kill the baby. They said, in order to save your life, we have to deliver the baby right now. And it was a very serious emergency situation. And that was my daughter, Jessica, and she's just about ready to give birth to my first grandchild from her. She survived because they took care of both me and the child. So it is a big myth that you ever have to kill a baby to save the life of a mother. You might need to deliver the baby early, and that could result in a death, unintentionally and unwanted. But it is a myth that you have to do an abortion, according to this definition, to deliberately kill a baby to save the life of a mother.
So I would like to tell you that after this we are going to have a presentation by Stephen Green, and you'll be presenting on homosexuality in Africa. Who is funding homosexuality in Africa? I think that's a good, also, it's a good thing for us to know.
Yes, a quick announcement. The government has cancelled our march tomorrow for security reasons. We had been able to bargain to be allowed to congregate on Friday. So we are really sorry about the inconvenience, but let them not put us down. Let us still congregate on Friday, same time, same place at the railway, and we'll still have our march and our prayer. We actually went to them and begged to allow us to pray, not to march, to just pray at railways, and they declined. So we understand their jitters, yes, but we will not let them slow us down. Thanks.
still need to, not publicly, but we still need to gather a lot of people to know who knows about it.
Yeah.
We will still do that, not in that public gathering, but for supporting the government statement that we can't discuss publicly yet.
She would like to talk to you. She's from People Daily, and she would like to get more details about this event.
Okay.
Do
have the floor. Wait 1 minute, please. Okay. And I think you'll need to be brief because of time. No, I hope it won't be that long.
I'll be very brief in an African sense.
Details.
Okay, I'll give this other guy a chance.